Brad, thank you very much. As you all know, this is being sponsored as well by the Subcortical Surgery Group, um, a user group. It's kind of by the users for the users. It's been dedicated to optimizing with the software that's been available, and now with a substantial increase in what we're going to be able to do, optimizing minimally invasive surgery to the subcortical space. There have been significant clinical and scientific research collaborations that have been established. There are a significant number of papers that have now been published, and we want to continue to lead the change in what we feel is going to be the safer and more effective utilization of minimally invasive, or I should say appropriately invasive treatments for patients with brain pathologies, subcortical and otherwise. Um, a, uh, a plug for the SSG. The more we have, the more strength we have, the more we build the science behind this, and the more of our colleagues we can encourage that this is the right way to do things. For many of us that are part of the SSG, it seems quite obvious that this is the way to go, but it's been an uphill battle for some of the time, and we encourage as many people to join and understand the technologies and the science that is behind everything that we are doing. There are benefits. There's a surgeon database. There's an opportunity to post cases. There's an opportunity for dialogue between surgeons, and there is an opportunity to publish with others. With that, we'll enter into the course at hand. I'm honored to have been asked to introduce Dr. Sughrue. For those of you that haven't read Mike's glioma book, wholeheartedly recommend it. If you do, you're going to recognize that I'm just about to pirate Mike's preface as the entry into today's discussion, but I think that there's some very important basic tenets that he put out there that lead into this discussion of connectomics. Basically, one, the surgical models that most of us have based our learning and our understanding and our surgeries on are unfortunately significantly outdated. Two, that the brain is a big data problem. 3 and 4 kind of go hand in hand. There's no such thing as an inoperable glioma, and glioma surgery is curative, not curative, but is helpful. And the one thing that I took away was at the end of Mike's preface, which was actually a comment from one of his fellow residents at the time. Just because it's not curable doesn't mean you have a license to do sloppy work. And I don't think any of us have been doing sloppy work intentionally, but I think we're all about to learn that below this beautiful surface of the brain that we've been looking at, we have an exciting potential of navigating our interventions in a way that has never been done before. And this will, in exponential ways, improve what we do for our patients. Mike attended medical school at Columbia, completed his neurosurgery training at UCSF. He was a director of the Brain Tumor Center at the University of Oklahoma. Under his tutelage, it grew to be one of the top 10 largest clinics in the US. Lectured all over the world, performed over 3,000 brain tumor surgeries. I think the published over 230 articles is probably already dated. Unfortunately, Mike's doing neurosurgery at Prince of Wales Hospital, so it means it's too far away for me to do my residency over again with him. So this is the next best way. And with that, I'd like to turn today over to Dr. Sughrue, and let's get underway.
Hey, thanks everyone. As you can see, it's early morning here, but hopefully it'll get brighter as time goes on. I'm going to take over the screen here. And I want to kind of preface, these first couple of slides are going to preface the talk. Now, this course is very practical. So many people, I try to never give the same exact lecture twice to the same group of people, in part because there's a lot, usually I learn stuff between there. And also because I always want to be expanding people's knowledge, even though I'm often talking about the same topic. So this course is going to be very practical. It's aimed specifically at getting to the point of what do we do with this information, the kind of information we've been learning through connectomics. And I think the best way to think about what we're really doing is we're operating on networks and around networks of the brain. And I'll go into deeper information on that. So we're using some software of a company I founded. So that's my disclosure. Part of it is because I don't know of any other software that displays the networks in this way. It really is a different way to think about the brain. So we're, again, going to be hopefully introducing some new thought processes. So if you look at what we're trying to do, okay, ultimately a patient walks in with the scan on the left, and we want to get them to the scan on the right with as few new problems as possible. Now, that's not always possible, and the patients don't always come in perfect. But what we're trying to do is get the patient through all the steps in the middle with as few new problems as possible. And given the situation, sometimes there are different goals, but the bottom line is that we're pretty good at this for motor, right? So when people have motor deficits, we know why they have them. And if you're doing mapping and tractography and spending a lot of time with paying attention to motor strip tumors, you're going to have, relatively few permanent weaknesses. You might have SMA syndrome or something like that, but we're pretty good at that. We talk about language. We're pretty good at that too. We're not bad, particularly if you look at people who are doing, language mapping and tractography and all these things. Even for tumors that are in language cortices, we still are performing, mid to high 90% of preserving the basic mechanism of speech. Now, you could argue whether people's language is perfect. That's a different ballgame. But what we're not good at is all the cognitive stuff. That doesn't mean that everyone has a cognitive deficit, but a lot more have it than we would accept for someone's hemiplegia rate than saying they're good at doing surgery. And it isn't because we don't care about cognition, it's that we don't understand it. And so when we operate on this insular glioma, we don't know what's running around here. Now, people who spend a little time studying tract anatomy know that the IFOF or the arcuate SLF are in the general vicinity of the tumor, but there's a lot we don't know. And so basically, we have inadequate information to make decisions. Now, Hugh Defoe coined a term called the oncofunctional balance, and for gliomas, this is a really useful term, but it's kind of true for anything, which is that always what we're doing is a trade-off. The best amount to cut out for oncological purposes is all of the tumor and a margin, right? There's no doubt on that. That's true for almost every tumor we know of, or at least in the solid tissue world. But the problem is the best for functional is none, right? So if we could get away with not cutting the brain, we would have better outcomes, right? The problem is that those two things are competing goals. And so what we're always trying to do is not define whether it's good to do 100%, because obviously it's always good to do that if possible, or zero. What we're trying to do is make a good decision. And I think the other thing we have to think about is, while it's great to talk about functional preservation, this is not the same goal for these two patients on the screen. It's hard to argue that if I decided that I didn't want to cut any white matter pathways or put them at any risk, that just removing the necrosis, leaving all the enhancement, which is the safest thing to do, we all know that, is doing this patient a favor, because those tracts that are nearby that are going to get eaten by this cancer if we can't get this under control. So, what are you talking about, functional preservation? There's no reason to preserve a tract for 2 weeks and then have the cancer take it out. That's not accomplishing anything. So there's an impetus to be brave at what we're doing. Having said that, look at the guy on the right. It's hard to argue that pushing the extent of resection by an additional CC is going to be worth the significant cognitive, language, and potentially motor deficits that we get with this tumor. So the bottom line is that the idea of maximal safe resection is really just a rephrasing of the term oncofunctional balance. It's a little more better way to, I think oncofunctional balance is a better way to put it. And ultimately, we're always trying to figure out where the line is that we have to stop. Now that's going to change as we get better information. We may move the line more to one side or the other. We may get less afraid of certain things because we know where we really have to stop. But the bottom line is we need more facts to really make good decisions in these cases. Now, I've been interested in the concept of cognitive preservation since I was a resident, when I noticed that many patients who had big glioma operations had problems. They just weren't paraplegia. And ultimately, if you get down to it, there's not a lot of good advice if you go out there and look to say, well, how do you do that? How do you not have patients who basically their cognition gets worse? And so, you know, the simple thing of stay out of the eloquent areas, which is a good advice. I mean, you shouldn't cut into the motor cortex if you can avoid it. We know that that deficit's pretty predictable. But the problem is we know that that doesn't explain everything. We know that there's no way that the entire frontal lobe is carte blanche. It's not doing anything, and it's just there to decorate the head. It evolved for a reason. It's just that it has some redundancy and it tolerates some things. And so that's not something we can really justify in 2021 knowing what we know about how the brain works. On the other side, people have gone the other direction and said, well, everything is eloquent. And of course, we know that's not true either. So if we use the term eloquent, meaning if you cut it, there will be a deficit, then this is not how the brain works either, because we know that there's forgiveness to an extent for certain things. Otherwise, we wouldn't be able to operate in the brain at all without everybody having some serious consequences. And we know that many people go on to live normal lives without having obvious neurological or observable neurological deficits. So what it really comes down to is that neither one of these simple platitudes gives us everything we need to know. Now, people have talked about doing cortical mapping for this, and I was very enthusiastic about this 10 years ago. And I went and did some of this and all this. And ultimately, I've come to the conclusion that I don't think that's realistic for most of these functions. In part because many of these functions, what we know about them, like, for example, judgment, is not really a single place in the brain. It's a very complex interaction of different regions and often different combined networks. So it's not really going to probably hack it that there's one place in the brain that the stimulator is going to find, and that's, if don't cut that and you're fine, which is what how motor basically works. Also, I don't think it's very easy to map these in most of the patients. So if you look at, you can do some 24-year-olds with low-grade gliomas, but when you start dealing with 68-year-olds with GBMs, these patients don't really handle these tests in a way that I think I would be willing to back off the tumor in order to spare what I'm seeing on the other side of the drape. But I think really the biggest thing is this: how can we preserve cognition if we don't understand its anatomy and don't have some kind of idea what we're there to achieve? The most important thing that we do in the operating room, the most important tool, is our mental and understanding of what we're there to do. And so what I'm going to argue, and I've argued for a while, is that no one-liner is going to answer this problem. We need to use facts and data to adjust our uncertainty. So I've given this talk in a forum many times, but I think, here's what I'd see as the future for how do we reduce the cognitive footprint of what we do. We can't leave everybody normal. Some people come in with horrible glioblastomas, or they've already have deficits and things. What we're there to do, and to be frank, sometimes it doesn't make sense to not cause the problem, because it may be that it's unrealistic to save it, or it's not worth saving, or from an oncological purpose, if you leave 80% of a tumor to spare a function, well, you may lose the battle. And again, it's always a difficult discussion when you really think about it in a detailed way. What we're really talking about is how do we make it so that the patients are as functional as possible with as much tumor control as possible for as long as possible, which is really what everyone here, I think, mostly is interested in. So there's a couple of things that we can do. The simplest thing we can do now, and this is what this course is about, is don't cut through the middle of large scale brain networks if you can avoid doing this. Okay, not always possible. We'll see some cases today that it is impossible or the network is gone. But the bottom line is, don't cut them if you can avoid it. Going deeper into this just for the purposes, and this is not what this course is about, because this goes into much deeper things, some of which are not totally implemented in software form, though this is one of our goals. Looking at the brain as a whole brain network and thinking about whole brain ramifications in that, like this basically the simplest thing is don't cut brain hubs and try to keep the path length of the brain as short as possible. Using machine learning to identify individual circuits. And of course, anyone who's heard me speak knows that we talk a lot about TMS for rehab. Of note, last week, there was a randomized controlled trial that came out in brain tumor patients that shows without any doubt whatsoever that at least for motor rehab, that this substantially improves outcome. So the bottom line is we should be doing this. Well, let's focus on the course. And there's two parts to the course. When we were thinking about how to do a course like this, the reality is that when you think about how do you implement network thinking, white matter anatomy, however you want to phrase it, there's really two different situations. And they're similar. A lot of the same principles apply for the same parts of the brain. But the bottom line is they're different because how you think about the problem is different. And I first noticed this when I actually attended a white matter course many years ago and was a junior faculty, and I was really interested to see because they had all these case examples. And what I wanted to see was how do you deal with this thing on the left, where there's no way to dodge the tracks. It's up against the tumor. And everyone was showing smaller cases like this, where they did very beautiful approaches to, come from the other side of the head to get to these things. And that's great. It's good to do those kind of, minimally destructive approaches, but it's not always possible. And so in order to have a full armamentarium, we need to basically be able to handle both situations where we're aiming at deep structures using trajectories, and we're dealing with larger area operations and more superficial tumors, or we're just disconnecting the tumor from the networks that are staying behind. These are two different things. And part of it is by covering it in two different courses, what we're trying to basically do is first repeat the same thing over and over again so that people start to learn it, but also to emphasize that there are different ways to think about cases using the set of facts and toolbox that we're trying to convey to people. So let's talk about this case in terms of disconnection. So it's possible to think about this as a trajectory, but this is coming pretty close to the surface. And more importantly, it's wrapping around multiple networks. So even if you were to drop a tube down to this, fundamentally, you have to separate this from the surrounding brain networks. And this is a bad tumor. We all know it's a bad tumor. And part of the reason that it's a bad tumor is most of these patients present with episodic memory deficits, usually pretty significant, or cognitive disorganization, or usually both. Now, they often get that if you don't operate, and again, these are pretty significant, challenges. But the data is becoming increasingly clear that these cases, if they're resected, do about as well as anyone else with a glioblastoma. So the median survival increases from about 2 months to 14 months. And they can often be at least internally debulked and got down to a reasonable extent of resection with acceptable morbidity. You're not going to leave this person normal. They don't usually walk in the door that way. That's how this thing gets diagnosed. But the question, of course, is why does a tumor that crosses the splenium of the corpus callosum cause memory problems? Splenium is not doing that. It's linking up the visual system to itself. And so that only makes sense if you start looking at it in terms of networks. So if you look at it, this tumor is a whole different beast. When you start looking at the networks around it, you see that it's tucked into the language system. You see that it's tucked under the sensory motor cortex. And you see that it's basically almost doing a 270-degree bend around the default mode network, which is plays a role in episodic memory as well as numerous other cognitive functions. So when we start to look at this, it becomes a whole different operation. And so this isn't just a parietal tumor that happens to be in the corpus callosum. It's a disconnection from these three networks, which are the main ones at risk in this corridor. So again, you can think about it lots of different ways, but ultimately, whether you do this through a tube, open, awake craniotomy, whatever you're doing this, your goal is to make these kind of cuts where you're cutting next to networks. It's a series of making safe disconnections that minimize the damage to the surrounding area. Even if you remove this one cell at a time internally with CUSA, or you take this out as on block as possible, it's still the same operation fundamentally from the brain's point of view. You're cutting next to a network. So Lloyd mentioned this. What we were aiming to do when I wrote the book was, when I first started doing tractography on every single case 10 years ago, it wasn't entirely clear to me how to really incorporate this. And ultimately, I spent a lot of time thinking about it and came up with the concept after talking to a few people. I borrowed heavily from Hugh Defoe, but also other people. And what ultimately you have to think about is that no matter how you're doing the case, whether you, again, start Mitch Berger style in the center of the tumor and work around circumferentially with the suction device, or you do it the way I do it, which is start with the disconnection, regardless of which, at some point you're doing that disconnection between what goes and what stays. And that is the fundamentally riskiest part of the operation. So ultimately, when we think about it, most of us were taught something like this. That's how I learned it. There was non-eloquent parts of the brain and eloquent. You want us to go to the non-eloquent brain, stay in the tumor, and just don't cut the corticospinal tract. It's good advice, but it just doesn't handle everything, especially when we start talking about cognitive morbidity. Many of these patients will tell you this, and especially if you study it, that they're doing worse than you think they are. And more pressingly, it doesn't even always protect us from weird speech and motor problems, which is something that everybody agrees we need to stop. And because there's parts of the language and motor system that are not in the traditional motor cortex and Broca's area that we think about. And this is because our models are inadequate. So whether we admit it or not, we're doing cuts next to brain networks. No, there's no way to do an operation where you obtain an aggressive resection without cutting next to it somewhere. Now, you might not cut very close to it, but you're making a decision of what goes and what stays. And just because we can't see the anatomy doesn't mean that it's a CSF sponge and we can go carte blanche. We have to think about it the same way that the skull-based surgeons think about preserving nerves in the cavernous sinus. And in fact, some of the nerves in the brain and the white matter are far more important to human happiness than the sixth nerve. So it's all there even if we don't know about it. And so what we're trying to do is think about what is necessary, what are we trying to save, what's possible to save. There may be a time where we say that there's cancer in the network. Well, then it doesn't make a lot of sense in many of these cases to leave the cancer there destroying the network, because the only thing worse than missing your default mode network is missing your default mode network from a cancer that's still there growing. So you at least should get the oncological benefit. It's not always the case that you should preserve these things. It's that you should be thinking about what you're doing and understand the consequences of what you do. And you only can do this if you know what the problem is. And ultimately, really grasping that is a critical step in our evolution as neurosurgeons. Now, I've done both of these extensively, and skull-based surgery has the reputation for being of technical mastery and difficult, long operations, and yeah, it's well earned. But there's a big benefit that the skull-based surgeons have that the interaxial tumor surgeons really haven't had. And if you think about it this way, how many cadaver courses have you gone for glioma surgery? It's hard to do one. I mean, it's possible. Actually, I've done a few, but it's not easy to do. And part of it is because skull-based surgery, you can get a cadaver and see the anatomy, whereas you can't really see the anatomy of the cerebrum. It's too complicated. And this is what you see on the left. It's just a blob. So despite the challenges of operating around this many structures, the anatomy is defined and visible. Whereas in interaxial tumor surgery, there are very few landmarks and a lot of traps. So what we were trying to get across with the glioma book, which was how do we do disconnections? Meaning that if you wanted to remove the whole lobe of the brain, or a whole region, how would you do that in a way that's minimally disruptive to brain networks and or major tract bundles that are in the area? Now, it doesn't mean you have to remove all of it, but if you had to do that, this is how to do it with the least amount of new significant neurologic morbidity. This is based on my best understanding 5 years ago when I started writing this book. But of course, as we learn more, we might find out that there's additional things. Some of these cuts may, I think I wrote in the book that at some point this may be the slide that somebody shows when we look at, that we think about when we see someone taking out a pineal tumor with a finger dissection. I mean, medical science evolves to where oftentimes what we think is high tech is barbaric in future generations. But in the meantime, this is I think significant improvement, because at least it's framing our thought processes on what we're there to try to do. And we're going to go into these and also these as kind of the 8 basic disconnections. Now, our software, as you'll see, is clustered and it works that way. It's basically designed to cluster this by around these disconnections. And what it basically does is that it will call different objects that are in the vicinity of that operation and put them on image guidance. But fundamentally, whether you use the software or not in practice, the network is there, no matter what. And ultimately, for example, if you're operating the medial frontal lobe, it's making disconnections with the endpoints of the superior longitudinal fasciculate, which is language or the ventral attention network. If you look at the cingulum, this is usually a default mode network and Salience Network, and with the motor cortex posteriorly. And that once you've made this disconnection, you've now transformed this operation from an eloquent brain tumor, or potentially eloquent, to a meningioma. It's microsurgery at that point. And oftentimes there are steps in here deeper in the brain, where, for example, around the ventricle, where the anatomy has visible anatomy and landmarks. But in the deep white matter, there are no landmarks. You have no friends. So really the only guideposts you have are things like adjuvants and deep understanding of tract anatomy of that specific patient. And it's just hard for humans to do that with the naked eye, but I think it's impossible. So if you look at this tumor, it's a big, medial frontal tumor. You can see that it's actually, if you look on the axial over here, it's bulging over to the other side. And many of us would look at this and think, wow, that's going to be a very long, complicated operation. And while it's not trivial, it's important to know that ultimately this can be reduced to a set of cuts with 3 networks: the DMN on the medial boundary, the CEN on the lateral boundary, and the sensory motor system posteriorly. 3 cuts. Now, the big question, of course, is the default mode network that's smashed around this tumor, is it actually doing what we think it's doing? That's a clinical question. We don't know what happens in this case if you just take it out. But it seems that if it's there, that you're probably increasing your morbidity going after it. So we might think about, what do we do with this boundary? And, do we leave a small rind of it, given that we know how it connects posteriorly? Again, clinical question, but what we do know is that there's evidence radiographically that these networks are up against the boundary of this tumor. And we know that the periphery of these tumors usually has function somewhere in it, and even potentially in the middle of the tumor. Now, if you look at this, we didn't get a complete resection here. You notice that there's tumor in the basal ganglia. That's not a very good trade-off, being in the basal forebrain, and so we left it. But you also notice that we're pretty aggressive, and notice that also we removed everything up to the front of the orbit, because ultimately, if you've made this cut, this is a highway to nowhere. Now, so you might as well get the benefit of having a margin, right? And the point of it is that it's not that giving this margin actually improves your oncological control, because we didn't even get a gross total. But what it means is, if you've actually disconnected it from its normal sparring partner, it's hard to argue that it's basically connecting in it's going to send useful signal in a totally different way than how it's normally does that. And so again, if it's disconnected, it's basically just there collecting cancer. So you might as well take it out. We might find out that needs to be addressed differently, but it ultimately is a better way to think about oncology, I think. So when we talk about disconnections, there's a couple caveats that we have to make. So the first is the disconnection is a concept. Okay, so if you're talking about a medial frontal disconnection, you don't have to do a frontal lobectomy, right? It's just if you needed to do that, this is the way to do it. It's the concept. You can modify it, tailor it, whatever. It just says if I'm in this area, I need to think about dealing with these and I'm removing an area like a glioma or an epilepsy operation of some kind. That these are the basic safe cuts, or what's at risk. You don't have to make the full cut. You don't have to take everything down to the ventricle. It's thinking about it in terms of what direction do I need to be safe and what direction do I not? And again, what I've emphasized a lot of times is you can't always save networks. So this is a case that we're going to go over, and you can see that the Salience network is really attenuated and the tracks are basically really draped around this tumor. Now, it's possible we might find out that these things, when you decompress it, all of a sudden they wake up and do what they're doing. But, ultimately, to go and leave 80% of this tumor thinking you're saving the Salience network is not rational. And what you have to hope in this case is this patient has another Salience network they can run off of. Now, that doesn't mean that we necessarily do sloppy surgery, but sometimes you may make a choice to ignore what the information is telling you and just focus on the tumor resection. But you're doing it now. So you might look at it and say, I can't save this Salience network. And when we start incorporating adjuvant things like TMS, we would just think, well, how do we rehab this patient? And how do we do adjuvant stimulation to get this patient over the line? And we've started thinking about our resections differently when we have this kind of information, because we know that there's likely to be, if the patient doesn't already have one, a cognitive or a motivational deficit for this kind of thing. And finally, there are times when even when you're on the surface doing a glioma operation, you're not going to be cutting next to the network because it's basically in the network, or there's networks on all sides of it. And I call this the surrounded on all sides cut. Now, there's some areas of the brain that this happens a lot. This tends to be one of them: the lateral temporal lobe, the lateral parietal lobe, and often the posterior inferior frontal gyrus are often areas where motor cortex, where there's just networks on every side of you. So in this case, you have a difficult challenge. And we know these are the worst tumors from a neurological standpoint. These patients often have serious neurological problems until they found these things. And you have to think about, what do you do here? Well, first thing, if you look at this case here, if we zoom in, I can't zoom in here. There's fibers of the language system that are U fibers that are wrapped all the way around this thing on all sides. And this patient had a language problem. So leaving it in there is not likely to preserve language. It's already the problem's there. What we think about is, first, that on all sides of you have potentially important stuff. And the second is, if you had to err on the side of what direction that you'd be more aggressive anteriorly, because we know the language system is going posteriorly. And so at least keep as much as possible connected. And that's useful information to guide. I have to be aggressive with this, or I'm not accomplishing anything for this patient, given that they walked in the door with this problem. We didn't put it in the language system. But how do we minimally disrupt that system in the purpose of doing the surgery? So again, it's not that this is formally a disconnection. It's not really in that it's a lesionectomy. But if you use the same basic principles that you would use had this tumor been in the temporal pole, it still is going to work okay when you're in the middle of the network. It's just that you have to go a lot slower. So, some operations are big and safe, and this one is slow and dangerous. So what I'm going to do now is I'm going to talk about the networks. For some of you have heard this talk before, or in some regard, it's going to be much more condensed and to the point. And what we're going to talk about, and we're going to go over this over and over again to this course. That's the reason we're using the software. We're going to talk about what they are, where they're located, and what they're basically doing. What trade-off are you making when you navigate this? Because again, it's all about trade-offs at the end of the day. As you see with some of these cases, there's no way to avoid the network. There's no, white matter preserving approach for this. And so what we're trying to, these are not the cases that we feel as great about, because the patient is going to likely have neurological deficits. We're not have a mandate to never have a neurological deficit in anybody we see. We have a mandate to get the patient into the best situation we can, given what they walk in the door with. So I guess the first question is, what is a brain network? And this is a new concept for us. It's not new to neuroscience, but it's the idea that there are areas that are not in physical continuity that have activity, in this case, bold signal, that are highly correlated with each other. And so we know that if two areas are firing most of the time together, they're probably doing something in common, and they're often directly physically connected with the white matter pathway. Not always, but most of the time. And so if you look at these two areas, for example, if we compare area 55B and area TE1P, these are both language areas. And what you're looking at is that if you look at their bold signal, this isn't directly from this is just an example. They line up pretty closely. They don't line up 100%. So this is from a classic paper by a guy named Randy Buckner, where he said, let's divide the brain into the seven total regions that have the most, where everybody is assigned to somewhere based on who they're most similar to. And so when they looked at this, they basically found sensory motor system fired as a unit, not surprise. So the sensory cortex is closer to the motor cortex than other things. The visual system and the limbic system. Notice this also includes the orbital frontal region and the temporal pole. The central executive network in orange, the DMN in red, the Salience Network in pink, and the dorsal attention network in green. Now, for those who thought about this, there's a lot of other networks that, if you've been paying attention to this, that have come up. So where are they? Well, it turns out it depends on how stringent you are. So if you say divide this into take every voxel and assign it to only things that are almost identical, then you get something like this, which is a parcellation scheme of 180 areas per hemisphere or something like that. You can divide it into lots of different ways. And when you do that, those 7 networks begin to break apart because they're networks inside of networks. And so if you look at the 7 networks, they can often be broken into, for simple terms, about 17 networks. And I'm not going to go into all of this, but I will note that the 2 most interesting ones. So the first is that the default mode network is actually has 4 main subnetworks. There's a core network. There's the language part of the network. There's a part of the parahippocampal gyrus, which probably does episodic memory. And there's a part in the superior temporal gyrus, which is probably auditory. And so if you look at the default mode network, those areas are all closer to the DMN than anybody else, but they're different than the core. So a lot of times what we've been talking about is the core of the network. And so, again, you want to, maintain all of this, but at some point this becomes infinitely complex when you think about all the interactions of these things. Also notice that the visual system breaks into 4 different networks as well as the CN. I can't tell you what all the other CN subnetworks are. I haven't spent enough cognitive bandwidth to go into all of these, but we're going to focus mainly on the core part of the CN for this course. So if you look at it this way, the 7 network model breaks into a 17 network model. So you can see that the core DMN is this yellow guy, but this little red area is the language system, which used to be part, if you look on this other side, part of the DMN on this other diagram. And so if you look here, if you look at this blue area here, that's the perihippocampal gyrus area portion of it. And so that's probably the memory circuit. And that's just probably why people with splenial butterfly gliomas have memory disturbance. I always thought that was fascinating why that would be the case. This is the anatomy of it. And so what it comes down to is many of these networks can be subdivided and are more complex than, the simple 7 network model. But we have to be able to simplify this. Now, there's also things that get called networks, like the multiple domain and ventral attention network, that are actually mixtures of networks. So they have different components of different networks working together, but they do a task that for schematic purposes is useful for us to think about the brain. So I can't take it, not all of these are part of the 17 network model. So when we think about network decisions, ultimately there's three questions. Number one, what is it relative to the core of the network, the core component that is generally, really linked to a lot of the neuroscientific data on. The second is, are we making a good trade by trying to save it? Maybe not, right? Depends on the situation, and we still have to be doctors. We can't blindly utilize, use techniques and always preserve everything. Sometimes we really are making a trade. And when we make that trade, we should ask, is it salvageable to save that part of the network? And it's, again, it really is a judgment call. These are things we don't totally know yet. But ultimately, there's no benefit to the patient to save a network for 3 weeks, and then have them die of cancer. So this may be a decision where they decide that they don't want treatment. That's a reasonable thing. But ultimately, if we want to save the patient and give them as much function as possible, we have to achieve oncologic control to the best extent possible. So I'm going to run through the networks. I'm going to start first with the default mode network because it's important and it's new to most people. It was, basically, if you really want to look it up, I think there's roughly 13,000 papers last time I PubMeded the words default mode network. It's extensively studied. There's, you can argue that people are still learning about it, so it's not totally defined, but we know that it's very important. And it's important in internal mental processes, things like imagination. It's abnormal in multiple mental illnesses. It's part of episodic memory in some components. It's important. And its epicenter is in the posterior cingulate gyrus. So you can see there's a lot of components there. In fact, that's one of the more functionally connected parts of the brain, meaning that if you understand what that area is doing, you can predict what other areas are doing more than most other parts of the brain. It's kind of a driver. There's an anterior cingulate component that's linked to the cingulum, and a lateral parietal component. This is the core of this network. Now, when we look at the language system, again, part of the default mode network, but in its extended version is a different component. And it's important to know that we have to divide, when we think about language, we have to separate the concept in our heads of speech and language. Now, this network model doesn't totally segregate those out, but in the speech production pathway, we have these areas here in the kind of Wernicke area. Notice that if you look up Wernicke's area on Google and look at Google in the images section, almost nobody has the same diagram of where it's located, in part because it's been poorly defined, because a lot of things in the back of the temporal lobe are part of language. So we're basically just going to say these areas in the back of the temporal lobe are part of the language system. And if you're operating around there, you should think about them as a unit. You have these areas in the parietal lobe, as well as the area 44, area 45, and this area 55B, which was discovered in the Connectome project as a language area. There's increasing evidence, including a case report that we wrote, a Sal paper by Eddie Chang with electrocorticography, and a group in Spain who recently published a case series, all showing that this is probably part of phonation and mainly motor function of the larynx. Well, this includes the SMA. So notice that this is a more comprehensive speech model than you're probably used to, because again, not surprising if you've looked at people doing electrocorticography during speech tasks and research studies, this whole area is lighting up in all sorts of different ways. So, the broken Wernicke model is heavily incomplete, and this probably explains why some people don't talk normally, even when we're not in, quote, Broca's area. Now, it's important to dissociate this from language and also from things like speech arrest. So there's a motor planning area in the ventral premotor cortex here called area 6R, and it obviously looks like it's part of the canonical Broca's area. That is probably where we get speech arrest when we do mapping, and that's almost always where I found it. And so when you're getting a speech arrest, what you're actually getting is you're not stimulating Broca's area, because Broca's area is a language area. It's part of the cognitive aspects of moving the mouth and tongue and larynx to make sounds. When you get this, you're probably getting the motor planning component of that, where you're actually contracting the throat and larynx and things so you can't speak. but that's more likely what you're doing. It's important to also know that the temporal lobe, all the way to the temporal pole, plays a significant role not in speech. So you're not going to see a speech arrest there, but in language, which is things like verbal memory. And so in the software, there's a thing we call the accessory language, but essentially what this is, and we published a paper in JNS on this last month, not JNS Neurosurgery, sorry. And what we found is that there's a series of U fibers that parallel the middle temporal gyrus that carry information from those canonical Wernicke type areas to the temporal pole. There's probably also things involving the ILF, and it's very complicated. But the bottom line is that this explains some of the anatomy of what we're trying to avoid. Now, ultimately, if you got a glioblastoma filling the temporal lobe, these areas are not salvageable, right? It's not worth saving because they're probably already disconnected. But if you're planning a smaller operation or trajectory, you might consider not going through that if possible. Now, if you look at it, other parts of the default mode network include this STG component. This is the auditory system, and you can see the auditory system has its own connections to the Broca areas, so that's interesting. And furthermore, the PhD section that I talked about is this little stem where the isthmus of the cingulus gyrus goes into the hippocampus, perihippocampal areas. And this has been a lot of really good recent studies show that this is probably doing episodic memory. So moving to a simpler network, that was probably the most complicated one we're going to talk about because it has multiple components. The Salience Network is involved in coordinating responses to stimuli, so being salient. And this has implications for pain, for emotional regulation. I think that actually the SMA syndrome is probably mostly related to the damage to the Salience network. In part, we published a paper recently showing that if you cut the frontal aslant tract, you get SMA syndrome, and if you make an effort to preserve it, you don't. That was in Cancer a couple months ago. And most of what this FAT is doing is hooking up the Salience network to itself. So it's hard to disentangle it, but notice that this area SCEF is actually the biggest portion of the SMA. And so ultimately, the motor planning areas are mainly areas of the default mode, central executive, and Salience networks surrounding motor areas. That's really what motor planning is all about. So we can't disentangle the control networks from motor planning. They're the same thing. And the central executive network has a frontal polar component. This area 8C, which is one of the hubs of the brain, for obvious reasons, it's linking up the CN, and this area here in the parietal lobe or in the supramarginal gyrus called PFM. And ultimately, it does what you would expect. It's executive function, working memory. There's a lot of really interesting studies on how it does this, but what its main job is to get the brain into energetically difficult states necessary for higher cognitive function. It's also the network that matures between pre-adolescence and adulthood. So if you think about it, this is the difference between being 12 and being 30. The dorsal attention network is a phylogenetically older network, and you can tell the closer you get to the motor cortex, the earlier you showed up in evolution usually, and the less variable you are. So this sits inside the intraparietal sulcus and the precentral sulcus right behind the MFG, the frontal eye field. The frontal eye field and area 55B are immediately adjacent to each other. And so ultimately, if you wonder why people who have frontal eye field problems also have speech problems, this is why. The intraparietal sulcus is laced with these things, and the fibers sit at the bottom of it. So when we get to the trajectory course, going into the anterior portion of the intraparietal sulcus to dock your port is probably not a great idea. And if you look here, there's a component in the lateral visual system. And so what the point of this is, if you really think about what links up the dorsal attention network, is the concept of the frontal eye field directing vision. This area here, the intraparietal areas, we know from macaques, which they have analogs to these, that basically have a three-dimensional representation of space. And these areas here are part of visual recognition. And so what it's designed to do is to maintain directed attention on things. And what the consequences to damaging it are not entirely known, because it's hard to dissociate this from everything else that's running next to this. So it's, many people have this, have language problems or motor problems. You probably are hurting people's ability to do higher cognitive functions through destroying the network. And it's not very big. You notice the track's not big, but it's, again, one of the main networks. And I would think about it as basically dropping people's performance and IQ tests. It may not drop their fluid intelligence, but it drops their ability to actually do the test. If you look at the sensory motor system, I don't have to teach everyone about the motor cortex, but I think what I want to try to get across to people is that the motor cortex isn't everything. And this is something that dawned on me one day when I was a resident. It's not really an epiphany, but let's say you removed everything in front of the motor cortex and everything behind the motor cortex, which is kind of how we think about the world, right? Save the motor cortex and its connections to the spinal cord. But if there's nothing telling it what to do, you're paralyzed. It doesn't matter that it's still connected. So we have to be more thoughtful on, it's not enough that the motor cortex is still connected to the spinal cord. That's a useful thing. And it's very rare that we get in situations where we're covering the whole premotor area. But the bottom line is that there are numerous other motor planning areas: the supplementary motor area, the ventral premotor area, the dorsal premotor area, and even there's this part of the cingulate gyrus that's dedicated to motor selection, that are necessary to have normal motor function, as well as the sensory cortex. Again, what we know from people doing brain-machine interface, it's been known for a long time now. I think 12, 13 years ago, when people first started publishing Nature papers showing that brain-machine interfaces could drive a robotic arm. So why aren't we doing this on everyone? And it's simple. Without sensory and haptic feedback, the limb is mostly useless. And so, again, we move heaven and earth to avoid cutting into the motor cortex, but probably don't think about the sensory system quite as detailed. But they're a unit. They come as a pair, and they're necessary to do this. It doesn't mean that there's never a reason to cut into the sensory cortex. It just means that you have to know that you're doing it and think about it in a thoughtful way before just going hog wild in there. Vision is complex, and we don't make a major emphasis on this because, in part, and maybe somebody is smarter than I am, they can think of this, but it's hard to conceive a way that you could preserve one part of the higher visual system, but not save the primary cortex and actually have visual function. But it's entirely possible that there's connections from the other side that feed these areas, like the lateral area, which is part of higher order visual recognition. So this is areas like MT and MST, which recognize objects. It has areas that recognize faces. The ventral stream is the what pathway. It identifies objects and faces. Particularly on the right side, it has an area that only recognizes faces. And the dorsal stream, which is the where pathway, which is up here, which, believe it or not, is actually extremely highly connected. Some of these areas are some of the hubs of the brain. So it's very interesting of that. But from a surgical standpoint, it's also localized that it's hard to see how you could cut one and not cut the other. But this is something that maybe we can dive into deeper when you get to this. Many of these areas are just very, very small. And from a surgical standpoint, usually most things that are really bad in the occipital lobe are taking out some kind of the primary system, probably has downstream effects on the other guys. And finally, the limbic system, you can see that it not only does it have the medial structures, as you see here, but it has the orbital frontal region and portions of the subcallosal cingulate gyrus, which is the target that they were trying to hit in the DBS randomized trials for depression. It's actually abnormal in everyone with depression. And so the limbic system goes a little bit deeper than how we were taught to think about it. It isn't just subcortical structures. Now, looking at mixed networks, the dorsal attention network has a guy who's the right-sided network version of it, which is the ventral attention network. The dorsal attention network is bilateral. The ventral attention network is only right-sided. It's an SLF-dominated network. You can see basically what it looks like here. And it's not clear if this is the neglect network, but a lot of evidence suggests it probably is. And basically, it seems wise to not destroy this if at all possible, because neglect is a pretty bad problem, particularly when you make it permanent. And so this is part of a lot of the right-sided parietal montages. The multiple demand network is a new network. And so ultimately, we don't know for sure what the consequences of it are, but some data suggests that the more of this you lose in a stroke, the more your IQ drops. And not surprising. Now, the problem is it's hard to disentangle this from the dorsal attention network, in part because some of the DAN components are part of the multiple domain system. The multiple domain system, as you can tell, probably has parts of the CN in it. It probably has parts of the dorsal, default mode network in it. It's a mixed network, and so it's not a clean thing, but it's a useful construct for starting to study what really needs to stay connected to what to minimize cognitive morbidity. And so it seems to be a good idea to consider this in some situations. Now, having said that, if you're preserving the DAN, you're probably preserving the core of the multiple domain network, but it doesn't mean that they're the same thing. Ultimately, what it comes down to is the reason these distinctions matter is that if you try to put all of this stuff on the image guidance and you say, well, it's just this whole bundle or the whole tract, it often becomes too hard to really know exactly, can't see everything because there's too much clutter. And so really getting down to the level of granularity, saying this cortex needs to stay connected to this cortex, to this bundle, makes it simple and easy to understand what your goals are without overloading your image guidance system with too much information. So running through it one more time, and then we'll the rest of this course is going to be, today is going to be exercises where we're going to actually walk through it. But so the default mode network, anterior cingulate, posterior cingulate, lateral parietal. The basic thing is deep internal cognition running monologue in your head. And the consequences for that involve those kind of problems. Speech and language are two different fundamental interlinked concepts. You have the auditory network and then this PHG network, part of the DMN. The Salience network is middle cingulate, anterior insula, and it really is pretty fundamental to being alert and aware and to initiate action, to pay attention to things. It's a part of pain and it's a major target for depression. The central executive network is this frontal polar 8C and supramarginal gyrus network that's part of executive function. The dorsal attention network is sustained directed attention, and its injury to it probably impairs your ability to focus, concentrate, to do complex tasks. And you see that it lies in the two sulci surrounding the motor cortex. So there's one in the precentral sulcus, and this is in the interparietal sulcus. And they're linked in this sort of J-shaped fashion. It's a bilateral network and has a lateral occipital component. Motor is more than the sensory cortex. It has multiple planning areas. Again, you can segregate this out in all sorts of different ways. The visual system is a multiple component. There are multiple components of it. The limbic system includes the orbital frontal regions, as well as the subcallosal cingulate gyrus. The ventral attention network is a right-sided network and is probably involved in neglect. And the multiple domain network is a mixed network. So what we're going to do now is we're going to hop on the software and we're going to walk through clinical situations where we're going to encounter these networks. There's going to be a lot of repetition because the same things come up over and over again. So for example, the medial parietal, medial frontal regions are obviously going to have the motor system in all of them. And so we'll give everyone a chance to log in, and then we're going to start with the medial frontal first. Okay, so if you've all got on the software, we're going to come over here, click medial frontal, and click launch. And when we go into the software here, you're going to select medial frontal on the left side. So when you click that, and this is going to be something we do over and over again, it's going to go and it's going to pull up a montage of different networks or tracks that are running around this area. This was programmed in by me for basically based on what was involved in the disconnection, and what I thought was, we worked with it and tweaked it to make sure that it was actually viewable and didn't overclutter it. And while this is loading, we're going to go through what this disconnection's evolved. And I'm an idiot, and we should be on the right side. So give me a second. Apologize to everyone. Okay, well, that's loading. So here we're going to see this is a really bad tumor. It's butterflying to the other side. You can see that there's tumor growing out laterally. Now, again, you have to have realistic goals with this patient, but it's possible that we can get them into a better situation than we are now. And so, well, that's loading. Let's just quickly go through the steps of this disconnection. So ultimately, what we're trying to do is we're disconnecting it posteriorly with the frontal aslant tract and the motor system. Now they're kind of next to each other because the aslant tract is hooking up the SMA to Broca's area and the Salience Network to itself. But that's this thing in red. Out laterally, there are going to be fibers of the superior longitudinal fascicular system. This is either the ventral attention network or the language system on the left side. So we obviously don't want to cut that. That defines our lateral boundary. Now, sometimes we don't want to go that near it, but other times we do. And medially, what we're trying to preserve are the default mode network and salience network here. Now, once we've actually got to the ventricle, your window into the corpus callosum is between the cingulum bundle, cingulate gyrus, and caudate head. Now, in this case, you see that this can be taken down to the orbital floor. Note that the orbital frontal cortex hooks to its system via the uncinate and via the IFOF. So making this cut it does disconnect the parts of the frontal pole from itself, at least medially. Laterally, it doesn't. The CN hooking out laterally into the SLF complex. But you're not necessarily disrupting the orbital frontal region in this way. And so it's possible to do orbital frontal preserving frontal lobectomies. Now, essentially, what you want to think about is as you're going down, and we're starting from the premise that you're removing the whole frontal lobe. It's all cancer. Not in this case, that's not necessarily what you would do. And in other cases, you may do much less. But let's start you understand to remove the whole lobe, you can always tailor it back. And so how I focused on is all the dangerous part is here and here. Everything else, well, if you make this cut, you've already made this cut, so after this point, it's an en-bloc resection. How do I zoom down quicker? Now, of course, again, as I pointed out, if you look at tumors, oftentimes they cross the corpus callosum. And we wrote a paper about this several years ago. Other people have replicated similar work. And the corpus callosum, if you've entered the ventricle, you've already cut it. So the challenge is not the corpus callosum, it's sparing the cingulate gyrus. And so if you basically make sure that you stay lateral to the cingulum bundle as you enter, it's everything between the cingulate, the callosal sulcus, and the ventricle is the callosum. And so this is how you stay safe when doing this kind of thing. Now, I mentioned orbital frontal sparing operations. And as you can see, how you would basically do that is instead of going all the way down to the orbital floor, you actually hook a left or right, depending on this, you angle anteriorly, and you preserve the connections, because this is how that part of the brain connects. And you think, why would you want to spare the orbital frontal cortex? Well, the evidence is pretty overwhelming that this is a major part of emotional regulation and how you maintain good social relations, inhibition, this kind of thing. It's unclear that if you make this cut and preserve this, that you actually save that function, but anecdotally, I've done it several times, and I think it probably does help. So you've heard me mention this a little bit. The medial frontal disconnection, what is at risk? The default mode network medially, the Salience Network posteriorly, that's also the frontal aslant tract, and the corticospinal tract in the back, also the language system laterally, though that tends not to be what we're dealing with. So if you look at this, this is a difficult case. And part of the reason is, not surprisingly, when you're talking about how bad this tumor is, first thing is that the butterfly portion of this tumor is running underneath the anterior cingulate portion of the DMN. And essentially, if you're exiting the callosal sulcus or damaging this, you're disconnecting the default mode network from itself. If you're above here, it's even worse. You're destroying a node of the Salience network, and you want to keep these guys connected to each other. So even though it seems odd that leaving a little rim of medial frontal lobe connected like this, and also at the back, that this would actually achieve something if you basically did a 270-degree disconnection, it's still keeping it mostly lined up. And I found that actually significantly improved my outcomes when I knew that fact. Now, if you look at the CST, this is right up against it, particularly the anterior portions of it. And obviously, in this case, you're looking for damage minimization. You're probably not going to leave this patient totally normal. They're not normal when they walk in the door usually, but you're trying to not hurt them worse and get them out of this mess to whatever degree possible. Because you never know. There's patients like this who actually do really well with chemotherapy and radiation, though they may not be totally normal people. If you look at the Salience network, this is really where this gets bad. So if you see, this is the middle cingulate portion, and this is the lateral insular portion. And between them, there's nothing really running. And part of it is that the fibers are making these huge bends around this thing. And this is the frontal aslant tract. You can see this is the core of it. We don't know whether cutting these fibers was damaging or not, but you're certainly hard to really do any operation without transgressing at least some of these. And it seems likely that essentially that these fibers are probably mostly not doing a whole lot. We don't know. So when I do this cut, I always do the lateral cut of it first. Part of it is I want to disconnect things from the language system, and I do combine this with cortical mapping. And if you do the back portion first, they can get an SMA syndrome, and then you won't be able to do the language portion. So you always do this part first because it also gives room to work. You want to basically have the tumor nice and loose before you start doing this part, because you need to see what you're doing in the medial portion. The little details matter. Whereas here, you're basically just making a cut in the white matter. So you don't need microsurgical details. You just need to stay out of the tracks as best you can. So that's your lateral cut. The posterior cut, you can see here in green, is posteriorly with the sensory system and the frontal aslant tract. And what you're going to think about is bringing these two cuts together with the aim of aiming to the ventricle. Once you're in the ventricle, you have anatomy again. You don't have anatomy until you get to that point. And you also know that once you're in the ventricle, there's no tracks running through the ventricle, so you're across. So when I do awake craniotomies and things like this, when I'm in the ventricle in all directions, and I put the patient to sleep, there's no reason. At that point, it's microsurgery. The third cut is the most important cut, because this is the cut where you can really rack up some serious life-changing morbidity. It's this medial cut. And the goal is to stay out of the cingulate sulcus and the cingulate gyrus and preserve as much of the medial frontal connections as possible. Now, where you define this is heavily dependent on the networks, but that's the cut. And then the last cut is to basically come over the top of the caudate and to use this in a, not really subpeel, but it's kind of the same technique, subpeel resection, to follow this to the other side as much as possible. And so ultimately, the key piece of anatomy to understand is that the corpus callosum is wrapping around the DMN and Salience networks, but it's not connecting them. It's connecting the superior frontal gyrus to the superior frontal gyrus. It doesn't really have a lot of connections to the cingulate. So we'll go to the images here. And you can see that what we have, there's three 2D views and a 3D view. The 2D views are probably more familiar to people. And if you look over here, because we have a 3D image, we have our slider bars over here on the right side. And so you can see that right in the front end, there's your DMN. And there's the DMN on the other side. Let's go to the sagittal. And we'll slide this sagittal slider bar. You can see that the track actually looks like it mostly makes it there. Maybe it's damaged at one point, but it's not totally disconnected. But obviously, this tumor is really doing something to that whole system. It's certainly not friendly. If you look at this in the three-dimensional view, you can kind of see what your goal doing and what's at risk. It's when you come across to the other side and deal with this portion, you're basically having to remove it underneath that network as you go through the ventricle. And so you have to basically turn this into microsurgery with anatomical landmarks. If you look at the Salience Network, you can see, like we showed before, let me zoom out here. So in this case, how I would personally think about this is you've got a long cut with this, and you're going to try to preserve this portion, but you're not necessarily going to try to save this thing in the front. You could try it, and it might be helpful. I might be wrong, but certainly it's a pretty bad tumor. So it looks like it's connected, and generally the Salience Network is worth saving, in my opinion. When you look at the CST here, now notice that we're doing transcervical deconvolution. So you can oftentimes see the face motor and hand motor cortex fibers coming out this way. Again, if you're staying out of the frontal aslant tract, you're also going to be staying out of the CST because they run parallel to each other. And so if you look here, this is the aslant tract. And you can see that a good portion of this, amazingly, is draped around this. Now, you don't know, maybe if you're really slick, you might be able to try to work in that window. But I think that the more realistic thing is that you stay in the tumor as much as you can, but you focus your efforts on making that back cut. Finally, just looking at this for interest, the central executive network. And if you zoom out here, and let's maybe take this to the axial view. So if you look at the bottom of the screen on the 3D view, this thing will snap you to a pure projection. Let's flip this around. You can see that this portion 8C is actually pretty close to it. So while even though what you would expect that this thing would be pretty well, the central executive network is pretty lateral usually. In this case, the hub of the network, the center of the network, is right over this thing. And so it's possible to work in this little window between salience, frontal aslant, CN laterally, and get into this, but you got to, this is your working window. And you have to think that you're making this lateral cut. This is cut 1. Cut 2 is with the aslant tract. Cut 3 is as best you can to get this off the callosal sulcus and coming down on that medial boundary. And then cut 4, of course, is going to across to the other side. Now, again, we would expect that this patient would have some neurological morbidity from this, but it shows that the networks are salvageable potentially, and you could probably remove a lot of this without having a tremendous amount of downside to the patient. And no one would say that this is a good tumor. It's a terrible tumor. So I'll give everyone a couple minutes to play with it. And of course, if you have questions, let me know. Well, to answer your question, Rob, the objects that get exported are DMN, salience, the corticospinal tract, the ascendant tract, and the central executive network. And what they have is the tracks are only going to be tracks. So they're just going to focus on the fiber bundles. In a network case, what you get is a set of blobs here that are the parcellations that make up that network, the cortical regions that are part of it, and the tracks that connect those regions is a subset of tracks. We have a standard protocol that will work. In short, if you have DTI capabilities on your scanner, it is ultimately it's completely possible to get this. So even though it uses a CSD algorithm to process the data, the acquisitions are very clinically achievable. So it's a 30 directional single shell, usually B1000 DTI. If you're interested, we can help you protocol it to get this. Now, obviously, if you get more directions, you get better data quality, but it also means more time. So it just depends on whether or not your radiologist, what they'll allow you to do on your clinical scanners. But we found that we tested this and that seems to work pretty well. Okay. Now, I'll do one last little thing just to give everyone the final orientation to this while people continue to work with it. There are other settings over here. They're not necessary unless you want to change the export of how it looks, or you want to make your own custom export. If you look here on this top panel, there's a plus that will take you to a generic brain that you can play with. And so, for example, if you hit dorsal attention network, you want to see that, you click that button on the left, and that makes you an object. And if you wanted to export this to image guidance like Stealth and Brain Lab, you click through it like this, and then this next button comes up, which takes you to the export screen. So we tried to make make these issues as easy as possible. You notice over here, everything I talked about in the lecture, I believe I've covered it. All of these guys are who they are. So if you decide that you want to add something, it's possible to be a power user. But again, it ultimately comes down to how detailed you want to get into this. And a lot of times, in the interest of time, I'll tell you that these networks are most of what's around the medial frontal that we know of. We might add something later on. Now, if you want to pull up track bundles, it's listed under a different tab, but this is really the basics. Yeah, hold on. If I want to pull this up, let me just unlock this really quick. So edit. Yeah, okay. So if you come over here, there's different ways where you can call individual parcellations. Here they are right there. If you really want to, if you really know what you're doing, you can actually just highlight the whole insula if you want, or the frontal lobe, parietal lobe, whatever you want to do. That gets a little bit loud pretty quickly. And then over here we have all the common white matter bundles. You can pull it off a list, including some ones that we're not talking about. Now, you notice that we focus mostly on networks because, again, it isn't as important that you preserve every fiber of the SLF as you preserve certain fibers. But of course, there are times where, particularly in the insula, where the key thing that you're at risk is the core of the IFOF. And so there is a reason to go into that. Okay, so moving on, and in the interest of time, we're going to get through as many disconnections as I can get through in this time period. But I want to make sure I cover the big three, because a lot of the other disconnections become obvious once you understand medial frontal, the posterior temporal, and the medial parietal. There are other ones are derivatives, or they use common principles. So we're going to talk next about the posterior temporal disconnection. And so zooming ahead here. So if you go to this one and so again, we come here. Make sure I get the side right here. Right sided. Okay, so while that's loading, I'll quickly go into this disconnection, how it works, what you're trying to accomplish. Okay, so you can see this is another glioblastoma. It's covering a fair bit of ground, mostly medially based. And so ultimately, when you get down to it, when you look at the anatomy of the temporal lobe from a white matter standpoint, you can divide the type of places that these tumors lie, in many cases, not all of them, but many of them, into one of three groups. So, and from a conceptual standpoint, this is extremely useful for thinking about how to operate in the temporal lobe safely. So you have the lateral group. The lateral group are things that are out in the white matter. The white matter pathways that we care about, IFOF, arcuate-based things like the language and ventral attention network. You have the medial stuff, which is in the hippocampus, and you have the inferior stuff, which is in the ILF. Now, obviously, these guys in red, I put it in red for a reason, it's bad, and these are different operations, and they're much more dangerous. In the blue, the hippocampal area, notice that there's a ventricle between these two. So once you're in the ventricle, everything medial to the ventricle is not this. It's not the speech system. So that fact is really important. So you're either operating in the lateral system, you're operating in the inferior system, but often you have to decide, are you in the system or you're trying to dodge the system? Or you're operating in the medial system. So when you think about, let's say I want to remove a tumor from the temporal lobe, a big complex tumor. We're not talking about something simple that you can just go and snake out of the surface, but something complicated. Ultimately, the basic cuts that you do depend on whether you're in the lateral system or the medial system. If you're in the lateral system, you notice that this tumor is circumscribed, and the depth of your operation is the ventricle. Right? If you're at the ventricle, you can't possibly have anything medial to you. But this is a very difficult operation. This looks easy, but these are the nightmarish ones where you're just trying to minimize damage because it's in the language system. On the other hand, if you come over here, what you're looking at here is the when you're using a more disconnecting approach, what you're doing is that as you make the cut, your goal is to get across the temporal lobe white matter into the ventricle where you're safe. At which point you can actually go in the medial hippocampus if you need to, all the way back to the occipital bowl. You can follow back to the anatomy, works that way. And what you're doing is you're working under the system. You're working under the speech system. You're working under the ventral attention network. You're working under the optic radiations, et cetera, et cetera, et cetera. Now, if you look at approaches to the atrium and lateral ventricle, this is a middle temporal gyrus approach, for those of you who've done your study, but it's a challenging one because if you really try to do a simple corticectomy and get into the atrium, you know that it's only so high you can reach. But when you're removing the temporal lobe for oncological purposes, you actually can work under that area pretty easily. And so where you put this cut matters, and it's a balance, right? It's balance. First thing, where you put that cut determines how aggressive your margin is, how aggressive your resection is. But the second is, it also tells you how easy is it to work under the system. And what determines how far back you can get is the position of the SLF arcuate complex structures, like the speech areas and the ventral attention network. Now, again, once you remove this, it is possible to work in the medial structures like the hippocampus, amygdala, And notice that there's an area of perihippocampal gyrus that's medial to the hippocampus. So when you remove the hippocampus, you still have to go a little bit further before you're actually at the PO base. And what this allows you to do is to work, if you look at this diagram here at the very bottom, it allows you to work pretty far underneath the temporal lobe and pretty far posteriorly. But of course, what you're really getting down to is, depending on where you can make this cut, actually, let me go one further back for a second. It determines how easy is it to work up and underneath the system. Okay, so it seems odd that you can basically lift up the speech system and operate underneath it, but that's basically what you're doing. Now, there are some times when the tumor is sitting up at the temporal parietal occipital junction, like the supramarginal gyrus. I don't have to tell anyone experienced that this is a very dangerous operation. And part of it is that it's not only dangerous because you're almost certainly, tangling with the white matter, but also it's very easy to get lost and end up in the internal capsule. It's very easy to get lost and injure the sylvian branches of the sylvian fissure. And it's very easy to really, get lost and not really, because ultimately the supramarginal gyrus isn't a C like it looks on the surface. It's actually twisting inward as on the white matter pathway. So it's important in these kind of cases a lot of times to start here at the STG, if you're going to tackle this, work up and slowly subpelially take this apart. And so you understand all the folds. And what you're trying to do in these kind of temporal parietal occipital junction cases is to turn this into a single cavity. All right, so just like you would with a meningioma or whatever, you want to make this to where it's microsurgery again. And so going in deeply, finding the boundary of the insula and working back into this helps you follow this in without just going blindly into this and getting lost. And that's where, once you go below the sulcal boundary, you're in the white matter, the fiber bundles that matter. And that's tiger country. So you don't have landmarks. It's very dangerous. So if you go through the steps, okay, so what's at risk here? So we've talked a little bit about this. Some of this should be familiar. The corticospinal tract is in the region. It's not at that much of a risk unless you're getting lost or you're at the TPO junction. What's really at risk are things like the language system, the ventral attention network. In this case, because we're on the right side, that's what we're dealing with. The IFOF, which runs at the temporal stem, you shouldn't hit it unless you're going too far back. And the ILF, which may or may not be salvageable depending on the operation, as well as the optic radiations. So you can see here, the CST, we have it on every single montage, but in this case, not, you'd have to get pretty lost in this case to hit it. But when you start going deeper, you have the ventral attention network, and the VAN is going to determine where this cut goes. And in this case, it's actually pretty clear of it. But ultimately, especially some language cases, it's going to be more anterior, making this a lot harder. You have ILF, which is going to be running underneath this. So, again, you can make a decision on whether you think you can and should save the ILF in this situation. Generally best to. But again, if you do a complete temporal disconnection, you're obviously cutting it. And then, of course, the optic radiations are sitting on the superior boundary of the tumor. So the posterior temporal disconnection, the first cut is this cut right here. And ultimately, you're basically trying to get a cut from roughly wherever the top of your temporal cut, whether you violate the SCG or not is a discussion based on the tumor location. But ultimately, what you're doing is you're paralleling this network. And the goal is to get this down to the ventricle. And not just that you hit the ventricle and see a little CSF, that you actually get this cut all the way across. Once you've done this, a lot of times the patient can go to sleep if you're doing an awake craniotomy, because you're across the language system and you're not at risk for causing neglect, et cetera. Because everything after that is just a standard temporal lobectomy, but this is the dangerous cut. So you do it first. Now, the other cut that you do is you're going to make a joining cut that goes from wherever at the superior boundary of this to, if you're doing, again, we're assuming you're doing a full temporal lobectomy, to follow and subpelize the STG from front to back. And what you're doing is you're trying to basically get this thing disconnected from the sylvian fissure. Okay, so I go until you see the insula, you go until you see this little, I call it the corner, where you're at the sylvian fissure, at which point you've disconnected the temporal lobe from the surrounding brain. The third cut, and I try to take out the temporal lobe on block, which is faster and easier. But regardless how you do it, ultimately, conceptually, you made this cut across the STG and disconnected this from the insula. You've disconnected this posteriorly down to the ventricle. And then this third cut is going to parallel the hippocampus from front to back and join them up. But once you've done that, you can actually remove the temporal lobe in one piece. Those are the three cuts. Now notice that these are three-dimensional cuts. So it isn't just that you make this cut across the gyrus, you got to take it, in 3 dimensions down and dodging the white matter as you go. But once you've done this, you remove the lateral temporal lobe. Now, the question, of course, is, would you remove the hippocampus or not? And there's 2 reasons you would do it. Number 1, there's tumor in it. And number 2, there's severe epilepsy related to it. This is a decision that you can make at the time. There's lots of debates about it and not really in the scope of this argument. But assuming that you found the ventricle, you can continue to work subpially along that surface. And this is what I put as the 4th cut, which is everything along the subpial surface you can do. Now, in general, you want to always remove the hippocampus last. And the reason you want to remove the hippocampus last is it's the best landmark you have. It tells you where the basal ganglia is. It keeps you from getting disoriented in the coronal plane. And it gives you an idea where the amygdala is. And if you remove it, it's hard to really always know exactly where you're at unless you're very experienced. But notice that you can actually just keep working under this. You work in the atrium, you can keep going. And the further back that cut is, the easier it is to do that. So if you have to make a cut here, it makes it a lot harder. If you have to work back here, less hard. Right. So that's why that.
We had a question I think it would be good to address right now, which is, what is your experience removing large parts of the hippocampus? Do you do a Wada test or only when it's the left hippocampus?
It depends on why you're doing it, right? And I think this gets into a really good question. So the answer is, if you remove a significant left hippocampus, what the consequences is in some people is verbal memory problems. Having said that, a big portion of it too is the accessory language system and the temporal pole. So the question is, it's hard to dissociate that completely, right? We know that there's something in that system that's mandatory. The hippocampus is probably part of that system, and the temporal pole is part of the system. But we also know that doing lid ablations for epilepsy, we don't see the verbal memory problems as bad, at least. There's some cases of it, but it's seen by the reports, it's a little bit better. So a lot of this is actually the temporal pole and accessory language system that's actually a big part of it. And it's just hard to dissociate that when you're cutting into the brain. Now, I think it's important to also know that it depends on what disease you're treating. So if you talk about the Wada test and these kind of things, this is a perfectly reasonable question to ask in temporal lobe epilepsy cases, okay? If you're talking about this case we're showing, which is glioblastoma, and let's say this was focused in invading the hippocampus, here is a debate, right? But if you're talking about removing, there's a cancer growing in the hippocampus, kind of is like, what are you talking about? This is already destroyed. And so the mandate is different. And so, and with low-grade gliomas, it's also hard to argue that a tumor infiltrated hippocampus is, contributing significantly to higher cognition, probably seizing. But regardless of which, it's hard to argue that the patient is getting a benefit by leaving a tumor infiltrated hippocampus, if it's really abnormal. You could argue it, but in general, this epilepsy control rates go up, the tumor control rates go up, et cetera. And if it transfers to glioblastoma, this becomes an irrelevant discussion. So I think it really highlights the point. The point is not that you never, ever cause a neurological problem. It's that you think through it a little bit. So we don't reflexively always remove the hippocampus. We don't never remove the hippocampus. And, if you're talking about a low-grade glioma, the evidence on this is pretty clear. Like, the more of it you remove, the less likely you are to have a GBM. And, you can discuss verbal memory, but it's probably best to get the cancer out to as much as possible. to the simpler question I'll show you right now. Depends if you're on Mac, it's a little different than Windows, but essentially, if you blow this up, whatever point you have, the software is designed to zoom into that point. So if we put 2 fingers on the mouse pad and you just zoom it, drag it in, it will zoom. I have a touch screen, so I can do it with the touch screen too. But the best thing is if you just have to use the mouse with 2 fingers and you just point at what you want to zoom into and zoom in. Okay. So, okay, so here we have our temporal lobe tumor. And you can see, let's look at it here in the 2D view first. So zooming in. So in our montage, we have corticospinal, IFOF, there's the ILF, the ventral tension network. Remember that the ventral tension network isn't identical to language, but it's kind of the analog. So a lot of times when language shows up on the left, if in left-sided montages, we use ventral tension network on the right because they're the same kind of basic anatomy. And obviously the optic radiations. So we'll zoom through quickly here on the corticospinal, not particularly at risk, but there you go. Let's go to the IFOF. Now, notice that in this particular case, this tumor is invading right here at the temporal stem, and that's where the IFOF normally lives. So it's not uncommon for IFOF in these kind of cases. And also, while there's some edema correction, it doesn't always, it doesn't go on forever. So if the edema is bad enough, it can still wipe out some of the tracks. So just be aware that there is limits to what it can do. But a lot of times it can show tracks right up to the boundary of tumor. But ultimately, if you look at the ventral attention network, you can see there's this posterior node right here in the temporal lobe. It's kind of where Wernicke's area is. It's not the exact same area, but it's close. So it's this analog. Now, if you look at this in the sagittal, this is the best one to look at because this is where this really comes into being. And if you come over here, what you can see is that is going to define your posterior cut. Okay. So if you look at this, the posterior cut is going to be about here. This is about what you can get away with. Now, you don't have to go right up to it. You can. I mean, depends on how much you believe in supramaximal resection and this kind of thing. But the bottom line is, going from here to here is your basic cut. And if you're going to try to remove all the temporal lobe and get all this out, which again, ultimately you have to decide that. But your basic cut is to go from somewhere here to down here, and then following the SCG to the corner. Those are your 2 cuts. Now, notice that again, one of the challenges is that that cut isn't just a one line, it's on all of these slices. Yeah, it may not be a totally straight cut. I mean, particularly if you're doing awake mapping for speech, it may force you to move in a direction you don't want. So you have to really, be doing this on the fly. But if it's nice and forgiving, you can land right there in the ventricle, straight across. You cut it down to the floor. And then the last cut is ultimately going to be here in the axial plane. And what you're going to do is you're going to basically come from wherever when you get to that corner of the Sylvian fissure, you're going to follow along right here. And that's going to join the 3 cuts, and the temporal lobe comes out. If you look at the ILF in this case, again, you can make the argument, well, the ILF is right there, so why do a temporal lobectomy? And that's totally reasonable. Again, you don't have to always do the cut to the extreme. You could just cut below it and then make a 3rd joining cut or 4th joining cut that does that. The concept is not always that you do a lobectomy. The concept is this is how to cut across network, next to networks. And ultimately, the optic radiations, you can see right here, are going to be on the back boundary of this tumor. You can talk about, do you try to preserve Meyer's loop? But it's going to be awful hard given that it looks like it's going into this tumor. Okay. So I'm going to show the insula one because it's kind of related. Part of it is with the insula, right? Let's, in this particular case, people talk about doing transsylvian approaches to insular gliomas, and it sounds great. It's elegant. And whenever possible, it's a good approach. I just haven't seen many tumors that are only in the insula. Maybe where I practiced, people wait longer. I don't know. But the bottom line is insular gliomas are often insula and temporal gliomas. That's the most common, or insula opercula, or occasionally insular frontal. And so it is rare that it is appropriate to do just only remove an insulectomy, because in this case, you're missing much of tumor. I mean, the tumor is following the U fiber into the operculum. It also very commonly is in the medial temporal structures. And so if we're talking about insular gliomas, in most of these cases, if you're really getting a good resection of these things, you're probably doing a transopercular approach. Furthermore, if you're not really facile with the transsylvian approach, not that you've split a fissure every once in a while, but you're doing it all the time and you're excellent at it, then it's really hard to get all these little angles, like, looking into IFOF and et cetera, and to really get a satisfactory resection. And so as a result, if you're really going to get good at insular gliomas, you have to really think about removing portions of the operculum to get a good view, and B, to deal with the tumor. And in this case, that's part of the tumor, right? If you actually look at this whole tumor here, let's look at the axial. So you see that there's a good portion of it here. And also getting back to this little corner, and then of course, given what's around here, like the language system, the transopercular approach gives you a much easier view than if you try to split the fissure for this. So while it's good to know the transsylvian approach, and I've used it, it's, again, to really have everything in your toolbox, you need to feel more comfortable taking off operculum when you need to do this. And so let's look at what's actually around this thing, okay? So obviously, in this particular case, the CST is a lot more involved in this. Now, if you look on the, let's get on the coronal view here. If you look on the coronal view here, right there is where, if you're going to injure things like the face motor fibers or hit the corticospinal tract, it's exiting the insula above the marginal sulcus. And while you might be able to get the operculum to retract up or work around here with an endoscope or something like this, I find that if the temporal operculum's off, it's a lot easier to see up here and work up here comfortably. And that's just because this is the riskiest part of the operation, besides maybe the lenticular striates. Now, if you come here and look at the real thing that's going to define your cut, it's the language system in this case. Now, let's just look at this on the 3D. Okay. So you see, essentially, the language system is not in this tumor, but it's around the tumor. Now, ultimately, I'm going to really zoom in on the key point, right? The key point in this particular disconnection, right, is we've got to get the STG off. We're not taking out the whole temporal lobe. There's no reason to do that. But if you look at this, there's a nice area right there where you have you're going to have to make a cut. So while you're not doing the whole disconnection, you're doing part of it. You do a little bit of that front cut 1 and all of the STG cut. Same cut, basically, fundamentally. And I find that it's often helpful for a case like this to take this cut until I see the ventricle, in part because then I know where the hippocampus is. And if I know where the hippocampus is, I know where the basal ganglia is. It's right below it. And so if I know the basal ganglia is, I know where to stop. in insular tumor surgery, you always think, how do you know how deep to go? Well, essentially, if you know where the hippocampus is, you make the whole resection even with the hippocampus in the sagittal coronal plane. And if you do that, you basically usually have a near total resection. So ultimately, in this case, the cut is a posterior temporal disconnection. And then I take the operculum, I dissect the fissure and pull it upward, and now I have a view of the insula. So what it comes down to is the cut in this particular case is a variant on the posterior temporal disconnection. It's not the whole thing. We're not making a temporal lobectomy. You could. I mean, it's like a lot of times these patients have temporal tumor, or a lot of it. And this patient's on their way there. You see that's actually starting to hook into the unset and things like that. But again, it's thinking about the disconnection as a concept, a tool in order to get you where you need to go. I think another really interesting thing about this one is just for interest of the sake of intellectual discussion. You come over here, here we have the Salience Network, and you can see this is the insula component of it. And when we click this, this is what it looks like on the other side. Let me zoom through this real quick. And what you can see is that the insula is, but the insular tumor has actually shoved the Salience network upward like this. And as a result, this patient actually presented with depression. That was one of their main presenting symptoms. And we know that the Salience network is part of depression. Now, of course, in this case, you likely can preserve this. It's mostly up here in the sulcus, but what it means is how I would handle this from a practical standpoint is just, I would be more aggressive kind of down here and less aggressive up here in the upper corner, just because I know that that's where that's located. And so this is kind of the thought of how you would utilize this information. The final thing about it is, if you look at something like the sensory motor network, you can see this is the parcellation of the sensory motor network. Notice we don't show the whole motor cortex because in the insula, that's usually not what you're dealing with. And many tumors have supersylvian components that are quite large, or they're going into the operculum. And sometimes you do need to develop a superior transopercular window, and that's a lot harder, right? Because not only you have this, but you have this, and you can come up with other things that are up there too. The frontal ascendant tract is, for example, looking here, is running over the top of this thing. You see that's where it's going to the Salience network. And so as a result, making superior opercular windows is sometimes necessary, but it may not always be possible. And it really, this is where these cases become pretty difficult. And so this is kind of the way we built the montage, the way we built it, is to make sure that we can cover as much, as many possible insula situations as possible. Though you may, if you really know what you're doing, add additional stuff. Okay. Next one we're going to do is the parietal, medial parietal. And then once we covered this, I'll take you through as many of the other ones as we have time for. You can see here's medial parietal. We'll load that. Make sure I remember what side this is on. Okay. Right. All right. So if you go to medial parietal, hit the right side, and let's let this load. I'll quickly go through this. Now, in this case, I think probably everyone recognizes that this is a MET. And so I want to talk about what happens when you're doing this for lesionectomies. Where does this fit into this, right? Because for gliomas, it's a different ballgame. Like oftentimes the brain and tumor are the same thing, or they look very similar. Oftentimes removing an area makes sense and a margin makes sense, but we all know for METs that's not the case, right? So you're not going to go recommend a lobectomy for this thing. And so the question is, how do you think about it? Well, ultimately, even if you're removing this thing on block, it's what is on the anterior surface of the tumor. And oftentimes you need to make cuts through cortex or around cortex to get into it. And and this is a really good case of where having a network understanding of this problem helps you get a better grasp on how to pick a safe entry point, because it actually did change our thinking on this case. So I want to run through it. So the medial parietal disconnection goes something like this, okay? You're on the opposite side of the motor cortex. So your cut, one of your cuts is going to be anterior with the sensory motor system. You have, just like you do in the medial parietal disconnection, the arcuate SLF combos are lateral and the DMN aspects are medial, okay? And ultimately what you're trying to do is think about this as a glorified supraparietal lobule approach to the ventricle. So people discovered this many years ago. We know that it's a safe approach. And the main reason it's a safe approach is, unbeknownst to our predecessors, at least I assume they didn't know this, all the networks are out to the side of this approach, and you're actually splitting between the DMN regions and the lateral tract regions, such as IFOF, optic radiations, and the SLF combos, like dorsal attention network and ventral attention network and language, etc. But what you think about is you're working in this little corridor between motor system in the front, DMN medial, lateral systems like dorsal attention and other things laterally, and the optic radiations posterior and inferiorly. You're trying to stay in that window as much as you can. So if you look at it, ultimately, once you've got in there, just like the medial temporal and medial frontal cases, once you have found the ventricle, everything after that is microsurgery. So it's just find your anatomic landmark, work in this space. So removing the splenium, the corpus callosum, if you're in the ventricle, you've already cut it. And you can basically, everything between the falx and the ventricle is corpus callosum. So it's not that hard to find it, but you have to make sure you see your landmarks. Otherwise, you may be removing something else. So it is critical to see the cingulate gyrus and the closal sulcus. It's critical to keep the PHG portion of the DMN, that part I was talking about, episodic memory. You don't want to enter that if you can avoid it. And it's the case that the tumors crossing the corpus callosum are not in the cingulate gyrus. Not to say that never happens. It just isn't normally how it happens. Now, again, you don't always have to go to the vent. You don't always have to go, take the corpus callosum out and this kind of thing. But this is, if you needed to do this in the worst possible case, this is what you would do. So basically, if you look at it, I talked about this being a box. There are 4 things that define the box: the CST and motor system in the front, optic radiations in the posterior and lateral portions, the ventral attention network in the lateral portions, and also the dorsal attention network, and the default mode network medially. Now, notice the dorsal attention network, one of its core portions is in the intraparietal sulcus. And so this is why this is a superior parietal lobule approach and not necessarily an interparietal sulcus approach. So even though the interparietal sulcus may look like this is a nice tempting short path to this thing or whatever, the front of it is not. You're actually going through a lot more things than you think you are. The back of it is a different structure ultimately. So it's important to keep that in mind when you're doing this, that whenever possible, you want to stand well on the off the bank of the parietal sulcus. It's an important area of the brain. So if you look at the cuts, now here, the cuts that we're making are lesionectomy cuts. They're right on the tumor. We're not thinking let's remove a portion of the lobe, but nevertheless, it's the same concept. First, just like the medial frontal disconnection, you do the lateral part first. You're doing mapping, you start getting speech and motor motor problems. It's going to interfere with the ability to do other tests. So do that lateral portion first. It also gives you more room to really work. Just like with meningioma, you always want to have the tumor debulked a little bit before you do microsurgery on it. And so you got to get room to work. And right now this is wedged in there pretty well. So this cut is a nice cut that makes it easier to work with. The anterior cut is next. This is the screen cut. It's on the dangerous portion up against the motor sensory system. In this case, The motor sensory system, this cut actually should be almost like a C, as you'll see that the fibers go almost all the way up to the surface here. The medial cut is disconnecting this from the cingulate sulcus. In this case, this thing right up to the falx for the most part, but it's when you go down in the depth, you really need to stay out of the cingulate gyrus if at all possible. It's doing something different. It's an innocent bystander, and it's doing things that are important. And then, of course, your back cut is just paralleling the optic radiations. Okay. So again, we'll go through this. And I'll show you the really interesting part of this, right? So this is a case that you would think this is a, quote, surface tumor. And, what does tractography have to offer this, and blah, blah, blah. And, we always want to ask those kind of questions. That's fair to ask it. But if you look, there's tracks all the way up to the surface here. So what that does is this, right? You might think, oh, that's a thin little rim of brain. What is this doing? Well, it looks like it's connected to the corticospinal tract. So you might cut through it. You might not get something obvious, or you might get a deficit that was unavoidable or the patient had. But in this case, what this is arguing to you strongly is that you need to be as close to the sinus as possible. And you need to peel this brain off, because it's not like it's not just this disconnected area. This is actually your window. And so, maybe some people are smarter than I am and immediately recognize that. But I think all of us have had that situation where you open the dura and you think, whoa, the hole in this brain in the way. And this is showing you that you can expect that. Now, if you look at, for example, the DMN here, posterior cingulate, and then you see here, you see right here is you have this little boundary right there. This is your cingulate sulcus. You can almost always find it. What you want to make sure is you don't cross it. So as you're working on this medial boundary, you got to be thinking, have I seen the closal sulcus yet? Because you obviously don't want to destroy it. We don't expect the ventral attention network to be heavily involved in this, but just for interest, again, if you look at this on the side view, not exactly like the language system, it's in different locations, but from a schematic point of what type of operations put it at risk. You can see here, there's a note of it right over the top of that thing as well. Okay. And just for interest, let's change this to the dorsal attention network. And you can, and if you look over here on the plus, any one of these things, you can actually expand it, and there's subcomponents that you can mess around with. Let's see, flip this. So if you look, the frontal eye fields are pretty close to this thing. So you really, that's your kind of your window for entering it. Now, of course, we know as we go along, we'll debulk this. Looks like there's a bit of blood in here. It'll get easier as we go, and that space will, open up and as the brain gets decomposed or decompressed. But it shows you that, in this case, even though it looks relatively simple, ultimately you're making disconnecting cuts with the DAN and VAN laterally. You're making sure that you maintain the corticospinal tract. In this case, it's mostly pushed around it. And, the optic radiations aren't in the mix here, but you want to make sure you preserve the the cingulate gyrus as much as possible.
Hey, Mike, we had a question that might be good to answer now. Can you address the value of using direct cortical stimulation to guide disconnecting cuts when the tumor is abutting a core functional network?
Yes, actually, that was I've done over probably 500 to 600 awake craniotomies using various aspects of this, though it's not anything like what we have now. And the answer is absolutely. I think that what's really useful. So if you look at it, you say, well, if you're good at mapping, why do anything else? And there's two reasons. One of the ones is that if you find a site, you really want to know what is the anatomy of this thing, what am I actually stimulating, and what do I need to keep it connected to? That's the challenge, right? So if you see something, what do you make of it? And everyone who's done mapping knows that you get false positives. People have speech arrests, and especially if you do subcortical work, you keep them awake during the disconnection. I actually usually keep them awake during the disconnection, particularly against the language and motor, where I have something very easy to study. I also do neglect mapping as well. It's very useful for the ventral attention network, and you do see people start having target cancellation problems on the left side when you're near the VAN type regions. But I think that the real thought process on it is that first you need to know what you're looking at, but then the second reason is some of these networks, if you looked at what they do, it's harder to think of a task that you do in the operating room that gives you a yes, no, clear answer that I would say, I would not resect further if this changes. That's the difference, right? You can do whatever neuropsych test you want, but are you going to leave cancer there just to prevent that problem? And do I trust it to that level? And I've tried all this stuff. You name it, I've probably tried it. And most of it, I said, I wouldn't leave cancer in this patient's head to prevent that from happening because I don't trust it enough. Whereas motor and speech, I have a really clear understanding of it. So I think that, while there's room for thinking about cognitive interoperative mapping, I think that people have been a little bit more optimistic of what its limits are. And more importantly, even if it's true, you have to know what the anatomy of what you're trying to preserve is, or you're not going to preserve it, most likely. As far as brain shift, this is a really important question because we all know it's an issue, right? And what I will say is that when I first started doing tractography, I thought this was a bigger issue than it really is. And the reason for it is this. So if you look at brain shift, the brain doesn't shift like over to the other side of the head symmetrically. It deflates, right? That's what's happening. You're reducing the volume of the brain. So first is that it's more of a problem later in the case than earlier in the case. That's number one. And it's more of a problem on the surface than deep in the brain. Now, where tractography is really critical is deep in the brain, because you can do cortical mapping, you can look at gyral anatomy, you have some landmarks to try to get an idea where you're at. But deep in the white matter, all bets are off. Like, how do you know where things are? It's too amorphous. And so what I found, having done, several hundred cases with this, is that it's usually within about around the width of your bipolar. So you can't say exactly where that tract is when the brain is shifted image guidance, but it ain't far off. So what you do is you say, okay, I'm getting close to where I think the SLF is likely to be. Got to slow down. And when the patient starts having problems and I'm near a tract, I believe it. And if they fail a couple times, I know I have to stop. So that's the first thing. The other thing about it is that when you think about the network maps that we're making, and you see, okay, the language cortex, well, that's going to be accurate when you need it. When later in the operation, you're not worried about the cortex, you're worried about something else. And what really throws it off more than anything is getting in the ventricle. If you've planned this operation correctly, and you've planned it in terms of a disconnection, when you get in the ventricle, you should be done with the cut. And so what this means is that when I make this cut, I make sure that it's even across, and I don't just dive straight down to the vent, drain the ventricle, throw this image guidance off, and then worry about this for the whole rest of the disconnection. The disconnect, I keep it even in all directions. And depending on the patient, it would take me 15 to 20 minutes before I was clear across, depending on what type of disconnection. I mean, medial frontal takes longer, but posterior temporal is, if they're really cooperative and in the groove, we could have that be across and have them back to sleep in 20 minutes or so. So the main thing about it is you can't trust anything off the cliff. There's nothing that's always accurate in the image guidance world, but ignore it at your own risk because it's not way off. Particularly in the deep white matter, it's not far from the truth. And what else do you have ultimately? It's, again, unless you have some kind of other OCT type parameter or some other really novel technique for seeing white matter in real time, this is the closest you're going to get, and it's very good. Okay. So those are the three basic disconnections. So if you understand why those guys have the boundaries they do, then some of these other ones are simpler to understand. And then we'll go through a couple more that are straightforward. And then we'll get into some, the complicated ones, which are just surrounded on all sides, no safe cut, and how do you think through those cases? So we're going to do the anterior-occipital one next. So if we go here, and we're going to search for OCC. Okay, anterior occipital. So the anterior occipital is basically a hybrid. The issues, at least, are a hybrid. Make sure I know what side it's on. Left side. Okay, good. Between the issues of the posterior temporal and the issues of the medial parietal. Has a lot of the same tracks, a lot of the same montages. But I want to show you that these cases are a lot harder than you think they are. And in part because the windows that you deal with, there are just a lot of things that are coming down to the temporal floor in the same place. And there are a lot of tracks running through these regions. And so I would have, before I understood connectomics, I would have thought these cases are a lot safer. And I want to explain a case that actually got me interested in this topic in the first place, which was a patient I had many years ago who had a tumor in that location, well away from where I thought speech areas were. I took it out, asleep. I thought I was mapping, so way away from the Wernicke areas. And the patient had absolutely devastated speech. It never improved. And I spent a long time trying to figure this out. And ultimately, what got me a believer in trajectography was when I went back and looked at what I had done. I'd cut the arcuate, portions of the SLF2 complex and arcuate at the very superior pole of it. So even though that I wasn't in the cortex, I was in the white matter. And I think that one of the best utilizations of this kind of technology, particularly when we get to the level of granularity that we can do with connectomics, is being able to go back and look at your mistakes that you didn't understand why it happened. Because if we don't have a way to measure our outcomes and our mistakes, we're never going to improve. So if you look here, this is the anterior occipital. This tumor doesn't look that difficult, and it's not the most difficult tumor we have in the brain. It's not an insular glioma on the left side or something like this. But ultimately, where these are useful are cases when you're basically not in front of the SLF complex and you're not medial to the interparietal sulcus and you're not in the occipital lobe, you're right here behind the junction. And this can be a useful tool for going behind the arcuate SLF type structures. That means, again, ventral attention network, dorsal attention network, and language system type areas. These are the one that when I mean SLF, that's what I mean. And so there are a lot of things in the mix. So the CST is here, not because we get into that often, but we included all the montages. But the dorsal attention network, if you remember, it's an L-shaped structure, it's bilateral, and it has a lateral occipital component. Okay, so the language system or the ventral attention network, in this case we're doing language, the ILF, the IFOF, and the optic radiations are all running in the deep portion. They're right next to the atrium of the lateral ventricle. And so you're going to tangle with them on your deep boundary. So if you look at the relationships of this, corticospinal, nowhere near it. Optic radiations, I don't think I have to tell most experienced people, they're going to be on the superior boundary of this tumor. The ILF, is, the language system is here, your anterior boundary. The ILF is going to be running right over the top of the tumor. So that's your superior and deep boundary. You see it's deep and superior. And if you look here, you have the dorsal attention network nice and in the way. Okay, so in general, when you're doing an anterior occipital cut, the way to think about this is you want to be behind these things as much as possible. Okay, and there's a big trick in this, which is it is even possible to go all the way into the hippocampus and work all the way forward. Again, it's the same concept as the posterior temporal disconnection. Once you're past the system into the ventricle, you can lift up the system and work underneath it. Same concept, just you're doing it from a different direction. Now, many of these patients, the only thing that's really here that is almost impossible to avoid doing this on the left side is the reading. This is where reading is located in the human brain. It's a visual to language transfer and higher order visual recognition. And many of these patients have alexia pre-op. But if they don't, then that's something I would tell them about. You can stay behind it. Maybe if you save the dorsal attention network and that kind of stuff, you might avoid it. But this is kind of what this is doing. This has the ventral stream and whatnot. So your first cut is the dangerous cut, and it's the cut with the dorsal attention network and ventral and the language network in the front. So you want to be behind it. Cut number 2 is over the top. This is where you're disconnecting it from the tracts, like the ILF, the optic radiations. And again, you do not want to enter the atrium, the lateral ventricle from the side. And pretty much if you've entered anywhere in the horn, in the lateral ventricle, directly lateral, you've probably gone through something bad. So you usually want to hit it in some kind of oblique direction, no matter where you are. And so in this case, the oblique direction is from below. If you look here, that blue cut is the posterior cut. This is the cut where, again, this can be arbitrarily placed, or you can base it on aspects of the visual system. I personally just arbitrarily place it behind the angle that I need, and that's your working corridor to get into this thing. And then, of course, the deep cut is when you make a disconnection. And this deep cut can be, you can take it as far as you want. That's the thing is that if you have tumors that involve this and go into the hippocampus, sometimes the anterior occipital corridor is the best corridor. So coming to the software. Okay, so if you look here, language system, and let's blow this up. Oh. And you come out here. Okay. So what you can see, there's the lesion, and there's the language system. So right now, when I tell you that these cases are harder than you think, you're already now angling back this direction. Okay. Now, if you come and look, let's look at the dorsal attention network here. Same thing. So notice that these things are right next to each other. Okay, that's because this is the portion of the visual system that actually talks to the cognitive areas like the language and whatnot. And so your first cut is going to be basically getting in and sneaking in behind this, and you're really angling posterior to anterior. So you're almost looking this way. So this is a challenging angle, but that's your disconnection, your first part. The ILF is going to make your superior boundary, same as the optic radiations. There's another part of your superior boundary, and you're basically going to work to get this disconnected, at which point you make the cut here and you scoop it out from the back. And so those are the anterior disconnections. And again, I want to emphasize that probably this is a little more difficult than you probably thought it was to get into it. But once you're deep and once you're to the ventricle, once you're clear of this, you're clear of all the lateral white matter bundles. And so, again, we can have a discussion about the hippocampus and things, but it's possible to work pretty far anteriorly in that corridor. We're making pretty good time. Feel free to interrupt me with questions. One of the interesting things about doing this on a video is that you don't know if everyone's falling asleep or they're gaining a lot of what you're telling them. So we'll have to hope it's the latter, not the former. Okay, so the inferior parietal lobule is one of the most dangerous parts of the brain. We all know that. It doesn't look like it's that dangerous, but if you go read Ghazi Yazagil's book, when he talks in his chapter on AVMs, he mentions that he thinks parietal AVMs are the most difficult and bad outcomes that he had in his series. And I always thought that was really interesting as a resident. And then I learned more about the brain, and now it's obviously he knew what he was talking about. And so let's look at, if you look at this lesion here, this is not a very particularly nefarious looking lesion. Okay. Now there's a lot bigger lateral parietal tumors, but at the end of the day, almost no matter how big this thing is, you're surrounded on all sides. There's something around you in most directions. So in this case, you have sensory cortex, you have the language system or the VAN in this situation, etc. And so the second thing about it is that this area of the sylvian fissure, as we pointed out earlier, is very complex. It twists in on itself. So often the first step of doing this, and it, I'll just save you the trouble and know that this is not a MET, it's a glioma. If you were to even if you're going to only do a corticectomy here, it's really important, particularly as you go deep, to not get lost. Connectomics networks of individual patient and used in place of canonical networks for population data. So there's a lot in that question. And in our particular case, what we're doing is actually we're doing it with diffusion tractography. So how the software basically works is it has an AI algorithm that looks at the tracks of whole brain tractography and assigns regions based on who is connected to who. It's a lot more complicated than that, but for neurosurgical purposes, that's what you need to know. And so once you know that an area is area 44, this comes out of the Human Connectome project scheme. What we're doing is we're calling the network the parcellations that are generally part of the language system or the ventral attention network. And this is just based on probably close to 35 to 40 papers that I've written about mapping these networks to parcellations. We use resting state in a different way, and we could go into it offline, but it basically, the challenge with resting state is that the stability of certain networks, particularly the DMN is pretty stable, but some of the other ones like Salience make it hard to do this in a way that I think is reliable, even with AI. And resting state is really giving us a different window into it. So we thought that what we do is hold structural connectivity constant. And by doing it with tractography, it's more robust, it's more easy for people to get. And it seems to, at least based on preliminary results, though this device hasn't been out for a long time, but to the extent that people have tried to correlate this with clinical features or TMS preoperative navigation, it's pretty accurate. We could go into this, it's a long discussion, but we don't think it's way off. So the point of a lateral parietal disconnection, the first step of it when you're dealing with this, and it's not really as much of a disconnection as it's a lesionectomy done with careful thought about where the networks are, is if you go in and you try to just dive around these gyri and just make a straight cut into this, it's a very good chance you're going to quickly pick off something in the deep white matter before you know you did it. So what I find the first step of these operations that I learned to do is to subpialize all the gyri around here. I was going to take out. I defined that with mapping, what was safe, what was not, and then subpialize it around the blood vessels so that I can make a single cavity to work in. So that when we're working around the networks, we knew where all the fibers were because they're all at the bottom of the sulcus. And so again, digging yourself in quickly into a deep dark hole is not a good idea here. So if you look at how to do this, essentially, I usually would start on the SCG side. I just think I understand the SCG more than I understand the superior Berkeley, and it's a lot more predictable. And slowly subpialize in this sort of circumferential fashion, working around between the windows of the blood vessels until I found the insula. Okay. Once I find the insula, then you know the depth, because behind here there is no insula and it's just gonna be white matter. But at least you now know that you have a depth gauge. And so then you basically work between the arteries until you make a single unicavity, at which point you now can actually have a discussion about where are these tracks. And again, a combination of image guidance, with the kind of stuff we're creating, combined with cortical mapping and cortical monitoring, which is really what you're doing in the deep white matter at the end of the day, it is really useful. But the key thing is, just like a petroglyphal meningioma, where the secret to it is to cut the tent and drill all the bones so that you get it into a single cavity. This is the same thing. It's the same concept. Make it into a single cavity. Don't work in a deep dark hole because you'll be more effective. So what's around here? And the answer is most things. So the sensory motor system is your front boundary a lot of times. These tumors are often in the sensory cortex. It's worth spending some serious time looking at your gyral and sulcal anatomy and looking at the network anatomy to get an idea of where this is actually located. But also, you have the language system or the ventral attention network, the dorsal attention network, optic radiations. They're all kind of in here somewhere. So again, these are some really challenging cases to have good outcomes. They're not challenging from an anatomic standpoint. They're challenging from a functional anatomic standpoint. So you can see, even in this small case, this thing has the ventral attention network, basically surrounding it. It's on its deep boundary. And you can see that you could easily, if you were to just quickly go in and start debulking this, go a little too deep and ding. And that's where a lot of the misery happens, that and injuring blood vessels in the area. So it really, I can't recommend this enough, subpially resect the gyrus in the area to the extent possible before really diving deep into these things. So ultimately, this disconnection is simple. You're surrounded on all sides. You have to use all the techniques you can to work around and wedge this out. It's possible to do this. We all know that we can resect tumors like this, but the disconnection is actually with multiple networks. And more importantly, the key step is don't dive too deep into the tumor. And log on, because it logged me out while I was. So if you come here, lateral parietal, right. And you can see that it's pulling up the montage. And again, you can see that there's a couple different networks that run through here. If you hit the left side, you're going to get the language system instead of BAN, because they're lateralized networks. And again, while this case is not the most difficult lateral parietal case you can have, we picked this in part because just to show you that even a straightforward case like this in the lateral parietal lobe, you can be easily surrounded on all sides. And this requires a little bit more thought than just say, let's just go in there and stay in the tumor. So if you look here, this is the CST. We're in front of it though, again, it is possible that you could, theoretically nail this, but you'd have to be pretty out of control. But also notice that these sulci are not straight up and down like many other places. They're a little more tortuous. That's typical. If you go here, click on the ventral attention network, and this is usually best viewed in a kind of sagittal projection. So let's go to that projection. And here in 3 dimensions, we want to take it and zoom it out until we start to see these things dive into the brain, because that's where they're actually located. And see that, here the ventral attention network is kind of running on this temporal parietal occipital junction. This is supramarginal. This is the bank between the angular and supramarginal gyrus. That's where that lives. And so again, it's not at risk cortically as much as it's at risk subcortically. So again, the whole point is where you're going to hit this, if you're going to hit this, is actually by getting lost in here somehow and going and taking a swipe of it too deep. Dorsal tension network is a little more medial usually, but I'll show it to you just for the purposes of learning. So frontal eye field, interparietal sulcus, lateral occipital lobe. And as we come out here, not really at risk, but you can imagine that a bigger tumor that abuts the interparietal sulcus would be. And we have the sensory motor networks. Notice that this is different than the cortical spinal tract. And you can see that, yeah, it's not in the sensory cortex, but it's in, the quote unquote S2 region. But many of these tumors often are partially sensory cortex. So it's often worthwhile to actually sit down and trace your soul site and know where it's actually located. This kind of answers it for you that it's not in the sensory cortex. Now, to dive into this a little deeper, for those of you who want to explore this further, if you hit the plus next to the sensory motor network, it will expand this out. And so you see here, we only have primary, but it is possible to add the other ones if you're interested. You can also only show the SMA, it's possible. And you can see how the frontal ascending tract is linking these guys up. It's even possible, if you really want to get this, to go down to the individual parcellations, though this may be more advanced than most people watching this are. And I think one other one that'd be worth showing, just in the interest of, since we have some free time, if you look at the multiple domain network, it's a pretty extensive network. Let's blow this up and let's turn off the right side. And then if you blow this one up here, here it has the core checked. So there's also an extended version of this on in some papers. But you can see that it's not really a single network. It's a collection of different regions that connect, and they have relatively tenuous fibers. Now, if we were to pull this on the right instead, what you can see is that, yeah, you're cutting it fairly close to some of these regions. So again, this isn't part of the montage, but this is just other features inside the software. And finally, I'll do one last one, which I think this means we will have covered all of them, which I'm amazed I got through all this. Hopefully people are still following along with me. Okay. So we'll go back to the frontal lobe. And so medial frontal disconnection is a workhorse, it's safe, it should be what you think about first, but what if it's this, right? And this is a MET, so it's a little different, but it's still the same concept. And getting into it, it is this will show you some of the thought process on how do you deal with it when the tumor, the lesion's in the tumor. So we'll start loading this up. And to answer the question while this is going on, there's a lot of QA on the front end. So for example, if it's designed where if you try to put a 6-directional DTI into this, it will crash. If it has to remove a bunch of directions or there's too much motion, it'll just give you, it won't work. I won't accept it. So, and there's a lot of stuff in the DICOM header. If you try to upload something that's not, brain imaging, it will crash. It won't accept it. Now, as far as more detailed SNR type things, it really depends on it, but in this particular platform, it's not a quantitative image. So we're not trying to calculate how many tracks or build a connectome and things like that. So ultimately, that's really more for machine learning applications, which is kind of outside the scope of the course. This software is mainly made to make gross anatomic pictures for surgeons. So we hit left lateral frontal. Notice there's a lot of networks here. Shouldn't be surprising that that we have this, sort of thing, because we know that this part of the brain is complicated. And while this is loading, we'll talk about this disconnection. And what you're really dealing with here is your main cut is basically going to be with the FAT, motor planning, and arcuate systems, which again means ventral attention network and language, anteriorly. With the central executive network, mainly that hub area 8C, superiorly, the central executive network anteriorly, and your deep boundary is wherever it needs to be. It's kind of arbitrarily defined. Obviously, we don't want to go into the basal ganglion caudate. That becomes an issue kind of towards the back. So your disconnection essentially looks something like this. Now, this didn't have the CN in here because when I wrote this book, we didn't have a picture of the CN. We didn't know what it looked like anatomically, but essentially you could imagine something like this. Now, notice that doesn't extend into the orbital frontal region. You try to save that if you can. And remember, it's connected differently than these other tract bundles in general. You want to try to not cut through the center of the IFOF if you can. Again, that could be part of your deep boundary too. Depends. Remember, the IFOF in this area is starting to fan out. So the IFOF, if you're cutting here, the IFOF fibers you're cutting are only going to here. What you don't want to do is cut it at the bottom of the insula. And now all of a sudden what you've done is you've disconnected all of this from all of this in a short time period. So that's the lateral frontal disconnection. You can see the Salience Network, the central executive network, the motor systems, frontal ascending tract. Those are the big things that are kind of in this region. And in this particular case, I want to highlight the fact that the Salience network is just draped on the deep boundary of this tumor. And if you look here, so is the parts of the language system. It's actually, you see here, this is that area that basically what it's doing is it's the speech arrest site. So the language areas are actually, all over this thing when you look at this, but essentially this is the speech arrest site, and this is the ventral premotor area, which is in that montage. We don't have it standardly in a montage, but it's something you could use in this case. And your first cut, as always, is with the dangerous thing whenever possible. So here we're making our first cut with the language system. Now here the language system is also, this part of it in front of it, but this is in it. But ultimately, you first say, I need to, at the minimum, keep this connected to this, right? Keep the anterior portion connected to the posterior portion. The next cut is over the top. And again, if you look at the central executive network, there's an area called 8C. It's an important part of it that's over the top. Or sorry, this is the anterior portion. This is the next part, it's operculum. And it's important when you deal with these. In fact, sometimes I do this cut first, is to know where the sylvian fissure is, subpialize it, and find the insula. Because once you know where the insula is, everything, all the tracks are deep to that. And so seeing a subpially, the depth of the insula, you get an idea of how deep you can go here, and that helps you guide your cut over the top and your deep cuts. Because, again, this operculum is injured, it's already cancer in it. And even if it's not, you're going to injure it in the surgery. But what you're really trying to do is not to go pick off things outside of that gyrus. So it's just like from an AVM, taking the arteries to the AVM is fine. Taking on passage arteries that are not, they're going somewhere else is bad. So cuts, do the posterior cut, disconnect it anteriorly with whatever is at risk. In this case, it's the Salience network and the speech, or the language areas, and then make sure that you keep whatever you can connected to its target. So Salience network, you keep it connected to the ascending tract, and SLF, you keep it connected to the Wernicke's area. Find the insula, find this little portion. It makes everything a lot easier and safer. That's true anywhere at time you're working in the supersylvian region, because this is how you avoid getting into this stuff where all the badlands are, or at least know it before you go there. And then, of course, doing your deep cut last. So let's just quickly walk through this case. So if we go looking at the central executive network, so you see this is going to define your anterior cut. Now here we're not at super risk, but also it's going to help define your superior cut. So if you look at this, there are these guys over the top here. And so you really want to, here we're not that close to it, but in a bigger tumor, you might be, abutting these things. Don't know what happened there. So here the Salience network is actually pushed anterior and down by this tumor. So this is going to help define how you do that front boundary. Now, here you're not going to be wedging out a region of brain. You want to avoid it. But the point of it is that when you get deep here, you want to be cautious on this boundary because you know that the Salience Network is doing that. And then the language system sits like so. So it's the same sort of thing. And so these guys, if this patient has any chance of recovering these, whatever they've lost, have to stay deep on that deep boundary. So now this becomes like an acoustic surgery where it's like the nerves are on the back of the tumor, which now is a helpful thing to know. And of course, in this montage, we have the sensory motor network as well. So this, if you look at this, we actually subset specifically the ventral premotor network. And this is mainly because when you're in this area, this is also probably where your speech arrest site is.